I feel extremely happy, honored, and most privileged. I think it's so. My topic is treating triglycerides for residual cardiovascular risk reduction with a particular focus on evidence-based findings. I thank Chairperson as well as Dr. GBK for his kind invitations. My disclosures, I have no conflict of interest in relation to my presentation. What I'm going to do for another 13 minutes, I think I was requested by Dr. Anbichelvan. Contents of my talk line includes introduction, triglyceride metabolism, triglyceride lipoproteins, subclinical atherosclerosis guideline recommendations, Lipid Association of India recommendations, new approaches to triglyceride lowering therapy, and of course conclusions. So cardiovascular disease remains the leading cause of morbid mortality. Presentation of CAD in India is at a younger age group. Indian patients have ASCVD at lower LDL levels than Western populations. And evidence from several cohort studies and Mendelian randomization support a strong dose-dependent relation between LDLC and ASCVD incidence. So genetic studies and epidemiological data implicate remnant lipoprotein as causal contributors to atherogenesis. So this particular IC modern type study, the overall weighted prevalence of dyslipidemia is 81.2%. So lipid abnormalities in patients with diabetes type 1, it is similar to control. Type 2, of course, as long as the optimal levels of control maintained within normal range, but for increase small dense LDL. When the control becomes poor, there is increase in all the parameters, including apolipoprotein B. So triglyceride metabolism, it circulates primarily as ApoB containing particles, and dietary triglycerides are absorbed in the gut, and chylomicrons are secreted into the lymphatics and are carried away by the thoracic duct, wherein they acquire ApoC2 as well as ApoE. LPL catalyzes the release of free fatty acids, and chylomicron dominant particles are cleared by the liver by the ApoE as well as LD1 receptor protein mediated pathway. ApoB containing VLDL particles are synthesized primarily by the liver. In the circulation, VLDL undergoes LPL mediated triglyceride hydrolysis. So we have the regulatory proteins like ApoC3, which inhibits LPL, as well as angiopoietin protein like 348 modulate LPL activity. So dysregulation at any step, enhanced hepatic production, impaired lipolysis, delayed remnant clearance can lead to sustained hypertriglyceridemia. So the regulation of lipoprotein from the gut, from the liver, and how they are metabolized by LDL, which results in hydrolysis. So triglyceride-rich proteins, VLDL and IDL in the fasting state, also chylomicron in the non-fasting state, and remnant-like proteins or the lipid proteins are the metabolic products of TRL after hydrolysis from LPL, and the effects of CETP, cholesterol ester transfer protein. They are increased in cholesterol, and RLCP can be measured by formula non-HDLC minus LDLC. Elevated RLPC causes low-grade inflammation. Elevated LDLC causes IgD without inflammation. So FFA released during hydrolysis can induce inflammation, and the next is endothelial barrier function as well as subendothelial lipoprotein transfer. If you look at the association between TRL remnants and endothelial inflammation, it is contributing to pathogenesis of CVD, and the inflammatory markers, we have the CRP, serum amyloid AA, and the additions molecules, cytokines, as well as peripheral white blood cells. So TRL, remnant cholesterol, and atherosclerotic plaque from the intestine, from the liver, how they are incorporated with AB, that is ApoB48 as well as 100, and how they undergo hydrolysis by LPL. So these findings support a role of the remnant lipoprotein C in the residual CV risk that persists in patients even when LDL cholesterol is lower to recommended levels. So the metabolism from the intestine, from the liver, and through various pathways. So these are all the non-HDL cholesterol, ApoB containing lipoproteins, RLPC as well as the plaque. The positive correlation was shown using intravascular ultrasound, which shows a macrophage increase in the macrophage content, indicative of unstable plaque, and also shown to induce a strong inflammatory response, and the lipoprotein particle diameter less than 70 ml or typically required to enter the arterial wall. Human chylomicrons range from 50 to 150 in diameter. Small chylomicrons and the TRL remnants or of sizes that enable arterial wall entry. LDL particles range from 20 to 25 nanometer, have greater penetration into the endothelial barrier. Subclinical atherosclerosis, we have the Copenhagen City Hall study, general population study, correlated well with the non-fasting triglyceride levels, and genetic and epidemiological data support a causal role of elevated triglycerides, and imaging modalities also demonstrate the structural and biological consequences of TRL. So CAC calcification scoring is a well-validated marker, and individuals with a severe hypertriglyceridemia, that is, it improves the risk stratification and therapy allocation. So coronary calcium scoring recommendations, NLA, coronary artery calcium scoring is an extensively available cost-effective rapid safe test that better identifies those at risk for ASCVD. Next is CCTA, beyond calcification. It permits assessment of non-calcified mixed plaque. Individuals with hypertriglyceridemia demonstrate greater plaque volume and higher prevalence of lipid-rich and increase vulnerability as well as high risk for ACS. Evaporate study clearly shown that the IPE, icosapent ethyl, reduce the progression of low attenuation plaque volume. So first pharmacological agent shown to improve coronary physiology, and carotid intermediate thickness and plaque burden measured by ultrasound also provides surrogate marker. And magnetic resonance imaging as well as positron emission tomography also highlights the importance of the triglycerides in terms of the endothelial activation. Next is these modalities demonstrate hypertriglyceridemia and triglyceride-rich lipoprotein elevation translate into measurable atherosclerotic changes ranging from subclinical calcification to vulnerable plaque characteristics and inflammations. So guideline recommendation, classification of normotriglyceridemia, hypertriglyceridemia, various associations, ACC, European Society of Cardiology, European Atherosclerotic Society, Endocrine Society. And these are all the triglyceride lowering effect of lipid lowering agents, statin, ezetimibe, PCSK9 inhibitors, bempedoic acid, and so on. And if you look into the effect of glucose lowering drugs on lipids, we have the favorable effect with the GLP-1 as well as GLP and GIP co-agonism as well as with reference to SGLT2 inhibitors. And ADA standard of care in diabetes, CVD, and risk management, lipid management for secondary as well as primary prevention. And if you look into the Endocrine Society of, European Society of Cardiology dyslipidemia guidelines, the icosapent ethyl has been recommended for high-risk patients. Next is Lipid Association of India guidelines, the need for accurate ASD, ASCVD risk estimation. We have the risk factors, risk markers, as well as the risk modifiers. These are all the treatment targets for lipid lowering therapy for various ASCVD risk groups. And the recommendations for the management of diabetic dyslipidemia, patient with the diabetes knows ASCVD, and diabetes patients with ASCVD. And recommendations for management and current management strategies, RSSD guidelines with reference to carbohydrate intake, fat, as well as proteins. And the current management strategies, LDLC remains the primary target. Next comes non-HDL, which is the co-primary target. Next is measurement as well as treating ApoB, that is a secondary target. And these are the recommendations which are also endorsed by American Diabetes Association. Whenever you come across hypertriglyceridemia with the varying levels, what to do, lifestyle modification, and what to do next. Next is phenotypic approach for management of hypertriglyceridemia. That is diabetes with the triglycerides 150 to 499. Next is no diabetes and no ASCVD with 150 and 499. ASCVD with the triglycerides 150 to 499 and no ASCVD, and adults more than 20 years, triglycerides more than 500 milligram. So according to ACC-AHF, moderate hypertriglyceridemia in patients at moderate ASCVD favors the initiation and intensification of statin. So statin remains the main treatment or remains the cornerstone for the management. It will be considered in patients with the moderate ASCVD risk, and the European Society of Cardiology and EAS recommended statins in patients high ASCVD risk. Whenever you come across triglycerides more than 200 milligram, it remains the first line therapy, and CTT meta-analysis confirmed statins reduce the vascular events irrespective of baseline lipid profile, and subgroup analysis also shown its improvement in diabetes and mixed dyslipidemia, and prove it TIMI also shows high triglyceride levels at baseline, and intensive statin therapy beyond their potency also provide modest 10 to 30% dose dependent reduction in triglycerides. So the burden of cardiovascular event persists in statin treatment individuals with hypertriglyceridemia. Studies also highlight the residual severe risk associated with elevated remnant cholesterol. Next is hypertriglyceridemia, omega-3 fatty acids, jelly study, Japanese study, they prescribe 2 grams on the top of the diet rich in the omega-3 fatty acids. So reduced IT also confirmed the extended findings of the jelly study. So in icosapent ethyl modestly reduced triglyceride by 20%, and observed CVD benefit appeared to be non-lipid mechanism. that is pleiotropic, lipid-independent mechanism, reduces inflammation, oxidative stress, and so on. National Lipid Association issued a strong recommendation for the use of IPE in patient age 45 years with ASCVD or 50 years with diabetes. And strength struggle was stopped early for fertility and showed no CVD benefit. Of course, with reference to formulation that was used in strength versus the Provit whereas reduced IT trial. Both EPA and DKHA lowers triglyceride, and EPA decreases LDL cholesterol, LDL particle concentration, HDL-C, and is better at inhibiting oxidation and inflammation, reduces inflammation, oxidation, platelet activation, vascular dysfunction, blood pressure, and cardiofibrosis, etc. Next is pemafibrate. So with reference to gemfibrosal pemafibrate, lower triglycerides and raised HDL, their CVD benefit has been inconsistent. Field and accord studies did not demonstrate significant reduction. So this pemafibrate is a novel selective PPAR alpha modulator and reduces serum triglycerides by 30% without any MACE benefits. So new approaches. We have the lomitapide, that is the microsomal triglyceride transfer protein suppressor, the production and secretion of TRL, and is approved in patients with homozygous familial hypercholesterolemia. Next is apolipoprotein C3 inhibitors. That is abundant component. It activates, it directly binds the LPL and restricts access to triglycerides, and it also disrupts the ApoB100 and ApoE-mediated binding to LDL receptor, thereby suppressing hepatic clearance. So it never interferes with the production. In fact, it delays the binding with LPL and also delays the hepatic clearance of TRL remnants. This particular slide shows the effect of the apolipoprotein C3 inhibitors, olmesartan as well as olezarsen. So these drugs bind to ApoC3 messenger mRNA and induces degradation by ribonuclease. Next is plozarsen, and this inhibits the cytoplasmic ApoC3 mRNA. Next is angiopoietin-like 3 inhibitors, Vijayakumar. It belongs to the family of glycoprotein. Potential inhibitor mechanism involves postprandial binding and subsequent enhancement of the LPL cleavage. So it inhibits the action of LPL. So the metabolism of triglyceride-rich lipoprotein is delayed, and there is a delayed clearance. So we have the Vijayakumar. Primarily it reduces LDL cholesterol levels up to 30%. Next is fibroblast growth factor, and the mechanism of action is shown in this slide. Promotes the expression of genes involved in fatty acid oxidation and facilitates VLDL-derived FFA uptake, as well as stimulates LPL-mediated TRL disposal in adipose tissue. So in short, hypertriglyceridemia may be associated with significant morbidity and mortality due to the elevated risk of CVD, pancreatitis. Common treatments such as niacin fibrates or combination of DHA EPA have not shown to reduce CVD risk in all patients. And of course, icosapent ethyl, purest form of this particular EPA, is unique among currently approved treatment in its ability to reduce the risk of ASCVD. The CV benefits of IPE appears to be predominantly related to serum EPA levels and beyond, and of course pleiotropic effects. Thank you very much for your kind listening.